Good evening and welcome to the Elevate Ventilator Management Experience, a three-part series webinar conducted by GE Healthcare. We from GE Healthcare take pride and honor in welcoming all the participants from India, Bangladesh, Sri Lanka and Nepal. So this is the three-part series and today is the first part of the three-part series of mechanical ventilation. We will be discussing the basics of mechanical ventilation. We have two very passionate clinicians who are practicing and advocating mechanical ventilation. We take honor in introducing Dr. Saneesh PJ, who is a senior consultant anesthesiology department, Anantapuri Hospital, Thiruvananthapuram, Kerala. He's a very passionate clinician, and he shares his knowledge, and he's a freelancing anesthesia video blogger. He have authored 2 textbooks in anesthesiology, and he is a AHA certified BLS and ACLS instructor. He manages his YouTube channel. I hope many of you would have seen his YouTube channel with the channel name Anesthesia Tools. And he hosts an academic website with online version of the anesthesiology teaching materials. Welcome, Dr. Saneesh. And we have the other speaker for today, Dr. Anoop Kumar, AS, consultant and chief intensivist from Baby Memorial Hospital, Calicut. He is an expert in infection control as well, and he has won many accolades. Among his contribution, he is well recognized for early detection of the Nipah outbreak in 2018, if you recall, and for his subsequent role in the containment of the outbreak. He was awarded the Best Doctor Award for Kerala by the Kerala government, as well as honored by the WHO. He is a member of many scientific and professional bodies, and an active evangelist of education and a passionate teacher as well. So welcome, sir. And before going to the session, we have a few instructions for the participants. At the bottom of your screen, you will be seeing you have an option for posting your questions as well as an option for answering the poll questions. While you can post your questions at any time, which will be taken at the end of today's session, we request you not to answer the poll questions at the beginning. Towards the end of session today, you can take the poll question, because once you take the poll question, you can't go back and change the question, and it moves to the next question. So it's a request that please hold on till the end of the session. So that's it. Without much ado, I request Dr. Saneesh to take the session forward, and we expect that there will be a very engaging session today. Dr. Saneesh, all yours, sir.
Thank you very much. Good evening to one and all, and thanks to GE Healthcare team for giving us this opportunity to present a 3-part webinar on mechanical ventilation, understanding the basic concepts and beyond. Okay, so this will be the first day. The agenda would be, we'll be introducing you to the concept, some terminology, basic concepts, ventilator knobology, and a little bit of graphics, objectives of ventilation, and basic modes of ventilation. Remember, module 2, you will have more clinical orientation, clinical coordination with the mechanical ventilation. Day 3, we'll have more updates, including COVID-19 ventilation. At the outset, let me remind you to experience breathing. So can you close your eyes and take a deep breath, hold it for a second or two, and then exhale with as much time as you can. Now you have experienced what we call as breathing, even in normal terms. Coming to our topic, mechanical ventilation. Is ventilation equivalent to respiration? No, because ventilation just involves movement of gas in and out. Even your room is ventilated, isn't it? But respiration involves gas exchange. When it happens at the lung, oxygen is taken in from the atmospheric air and carbon dioxide is washed out. That is external respiration. What happens at the tissue level is called internal respiration. So using mechanical ventilation, we just ventilate the lung, but when you do it intelligently, sensibly, you give the body the best opportunity or environment for gas exchange. That is how we help our patients. Now, what happens during physiological ventilation? You know, when you just took a deep breath, your diaphragm contracted, your chest was expanding, negative pressure created inside the thorax, and the air is drawn in. Then when you exhale, the diaphragm goes back to the normal position, the chest cavity contracts, and passively the gas mixture is exhaled. This is physiological ventilation. But when it comes to artificial mechanical ventilation, gone are the days of negative pressure ventilation. Here actually we use a machine to create a given amount of flow or push in a given mixture of composition, given composition mixture into the lung at a particular rate, at a particular quantity, and other characteristics specified. So that is mechanical ventilation. Now I hope you understand the difference between ventilation and respiration, and our normal physiological ventilation and the artificial mechanical ventilation through positive pressure ventilation. A bit more about the gas exchange, because subsequent discussion you need to revise this concept. When you inhale the gas mixture, the atmospheric air goes into the tracheobronchial tree, and then it goes to the alveolus, which is a conglomerate of sinus, which is profusely perfused by the alveolar capillaries. The oxygen contained in the atmospheric air leaks through the pores into the capillary, where it mixes with the deoxygenated blood, combines with the RBCs, which are deoxygenated at this point of time, and gradually as RBCs accumulate more and more oxygen, it becomes oxygenated and turns into oxygenated red blood cells. Again, what is left is carbon dioxide coming from the tissue level that escapes through the capillary membrane into the pores and gets into the alveolus, and during the passive process of exhalation, it is driven all the way through the tracheobronchial tree in a reverse direction and expelled into the atmosphere. This is what happens in physiological gas exchange. And now the question is, when is mechanical ventilation needed? Whenever you get a textbook or a website giving the indications of mechanical ventilation, they can list any number of indications in any number of classification. The simplest thing I think is, whenever somebody struggles to keep his oxygenation going, you need artificial support. When his ventilation is compromised, he is unable to wash out his carbon dioxide, he needs mechanical ventilation. And when somebody's sensorium is down, compromised, airway protection is required, you need artificial measures to maintain airway protection, and of course it will lead on to a requirement for assisting the ventilation artificially or mechanically. So in broad categories, these are the three broad indications when mechanical ventilation is needed. Right from the school days, when we were taught about respiration, we are all taught that the lungs are like balloons, inflatable organs. So here is the cross section, which probably we would have learned from your upper primary or high schools. But the diagram also shows some pressures labeled. Forget about it at this point of time. We'll catch them each one of them as and when we come across or when it is relevant. Back to the balloon concept. Balloon, the simplest property we can explain is its distensibility. That's when I thought we'll start by describing what is called compliance. Compliance is simply meaning distensibility. If you give somebody a balloon, he can simply inflate it because the balloon, that material is distensible, it's compliant. Okay, suppose the same person, if you give a football that also requires inflation, but by simple maneuver with the same amount of energy work, you cannot inflate it. So what is that differentiates between a balloon and a football is the property of distensibility or compliance. So in scientific terms, we can say compliance is change in volume for unit pressure change. Okay, delta V by delta P. Fine. So if the compliance is good, lung is good, working well, compliance is compromised, something has gone wrong. So the normal compliance value, we'll remember it as 50 to 170 mL per centimeters of water. That means every centimeter of water pressure change, there'll be a volume change of around 50 to 170 mL. Once you get the patient intubated, things are slightly different. For males, the value comes to 40 to 50 mL per centimeters of water, and for females, 35 to 45 mL per centimeters of water. Now the second terminology is elastance. This is the tendency of a structure to return to its original form after being stretched or acted on by an outside force. This is simply the property of being rigid or refusing to change its complexion or the volume. Compliance is the reverse of elastance, or the elastance is 1 by compliance. Okay. So if you are asked to calculate the amount of pressure needed to attain a tidal volume of 500 ml of a patient whose compliance is 100 ml per centimeter of water, how do we do it? For every centimeter of water, the lung distance by 100 ml. So first centimeter is 100 ml, second 200 ml, third 300 ml, next 400 ml. So 5 centimeters of water will give you a volume of 500 ml for this particular case. So this is just to emphasize the idea of compliance. Next property is resistance. These words all look the same, but the meaning is different for each. It is the measurement of the frictional forces that must be overcome during breathing. To reach the respiratory unit, the air has to reach all the way down to the sinus. So there will be a tracheobronchial tree, the volume or the lumen size, the resistance offered by the mucus, the smooth muscles, everything will have to be overcome. So part of the work is to overcome the resistance offered by this. The best example with which I can explain is a scenario of asthma where there is a bronchoconstriction, where the smooth muscles in the tracheobronchial tree are constricting, plus there is mucus effectively reducing the lumen size, causing more resistance. So overcoming this resistance, the strategies adopted must be different from probably strategies to overcome the stiff lung scenarios. So resistance is pressure divided by flow. So unintubated patient, the normal value is 0.6 to 2.4 centimeters of water per liter per second. And intubated patients, it comes to approximately 6. So now I'll introduce you to 3 different scenarios. This is basically a simplified illustration to make the concepts clear. First one is a normal lung unit. You can see the lung unit getting inflated. So you can see the change in volume over the time. Okay, clear? So the second scenario, the lung is stiff. So it is difficult to inflate or distend the lung. So what happens is, with the same amount of work, you will get a reduced volume, and then beyond a particular point, you cannot distend it at all because it is become non-compliant after that, or there is a case of reduced compliance. Okay, so reduced compliance means the volume attained will be less compared to the normal. Third scenario, where there is resistance in the trajectory or the way to the lung, as it happens in bronchoconstriction. Here actually the lung is okay, compliance is okay, it can distend to the same volume as you get in normal, but you need to be patient, you need to overcome this resistance, you need to give that bit of extra time to distend it to the same volume as a normal lung. Again, remember that if you don't give enough time, you will be compromising the volume because we have to overcome the resistance. So this is a case of increased resistance. B is decreased compliance. Okay. So coming to the previous analogy, imagine this is the lung, the balloon is good distensible. Football, lung like a football, it's very difficult to distend, compliance is less. Plus, if you are asked to blow the balloon through a tube, you have to overcome the resistance offered by the narrow tube also. So you need to be patient, give enough time, otherwise you will not attain the volume. So we'll use this thinking to solve problems when you are troubleshooting the mechanical ventilation issues. Next, everybody speaks about time constant, especially when you are speaking about COPD ventilation. It's nothing but the product of compliance and resistance. Its unit is in time. So it represents both passive filling and passive emptying. So either for filling and emptying, it comes into play. Here in the graph, you can see the percentage of equilibration value, and in the x-axis, you get time constant. That means one is one time constant, next segment is second time constant, 3 is we are giving 3 time constant, like that. So during the inflation, after one time constant, the inflation comes to around 63.2%. If you wait till 2 time constant, it will come to around 86.5. You give 3 time constant, it is 95% of time. 4 time constant 98.2, and 5 time constant is almost touching the 100% inflation. So the same applies when during the passive exhalation also. After one time constant, almost 63.2% is exhaled. So what is remaining is maybe around 37%. Similarly, after 2 time constants, you must have exhaled around 86.5%. 3 time constant 95%. So again, we'll come to this point when we are discussing COPD ventilation. Now, so after this 3-day program, you should be confident in approaching mechanical ventilation scenario when you take handover and all. So that we should be familiar with the knobology. What are the knobs or settings that we usually come across? We'll go step by step. Of course, there will be something called mode, FiO2, tidal volume or pressure control. The other values will be respiratory rate. There will be an IE ratio, what is something called as PEEP, pressure limit. So we'll go slow one by one. We'll try to be familiar with each of what the knobology, what it means. First, this is the diagram when a lung is at the end of expiration. You check the airway pressure. This is the baseline pressure, whatever it is. What is inside the lung is its functional residual capacity. Now you are pushing the tidal volume into the lung. So the lung expands. Now the volume contained is FRC plus VT. You can see the pressure going up. So what does it mean? When you push gas mixture of a given composition, of course, into the lung, there will be an increase in pressure because alveolus is a cul-de-sac. So if you plot it, depending on the volume you are inflating, there will be a pressure change. So these we can see in a different angle. If you are going to control the volume, the pressure becomes a dependent variable, right? If you are giving 100 ml, it will come around maybe in this example 12 or 13. If you push in 200 ml, the pressure becomes 20. You don't have control over this side. Suppose you think the other way around. You inflate so that the pressure becomes 10, then you end up getting around 60 ml of tidal volume in. If you inflate to a pressure of around 20, probably in this case, you will get a tidal volume of around 200. So here what I want you to understand is when pressure is the control variable, volume becomes a dependent variable. When volume is the control variable, pressure becomes a dependent variable. And this is volume control ventilation. When you take pressure as the controlled variable, it becomes pressure control ventilation. Simple, right? So here we control the volume. You have to face the consequences of the corresponding pressure. Here actually we are controlling the pressure, we are setting the pressure, then you have to adjust or manage according to the volume that is delivered. Here we are controlling the pressure, here we are controlling the volume in the first graph. Again, one more thing, the compliance, I said the distensibility, that is not universal throughout. Here in this graph you can see that initial part, for a small change in volume, the pressure change required is very high. Here the compliance is delta V by delta P around 4, but in this part the curve is much steeper. So for a change in volume of 50, the pressure change required is only 2.5. Here the compliance is around 20. That means in different phases of inflation, the compliance characteristics also will change. You can remember the analogy of a balloon. Initially you can inflate it, after a small resistance you can inflate it better. After a particular point of time, the more you exert pressure, the change in volume is not that much, because it will go to something like a plateau. Okay. What is FaO2? Fraction of inspired oxygen. Here this is not exactly the blender. You have a blender with, which is supplied by an air supply and oxygen supply. So if air is not at all used, you will get 100% oxygen. If oxygen part is not at all used, you will generate a 21% oxygen, FaO2. In between, you can mix and blend and create gas mixture between 21 to 100%. So that is what we mean by setting the FaO2. That depends on the hypoxemia or the degree of oxygen requirement to the patient. Now we concentrate on respiratory rate. Initially, I asked you to take a good breath. So what happens during breath is, first you inhale, then exhale, there will be a pause, and again inhale, exhale, right? So what constitutes one breath cycle is from the beginning of inspiration to the beginning of next inspiration is one breath cycle. Okay. So concentrate on this diagram. There is a particular point of time when inspiration changes to exhalation. This point of change from inspiration to exhalation, we can define the onset of exhalation. So from this starting point until this point is inspiratory time. From here till the next inspiration is expiratory time. Now you know what is inspiratory time, expiratory time, right? One more terminology comes in here. Okay, IE ratio. IE ratio is simply the ratio between the duration of inspiration to expiration. Normally it is around 1.2 to 1.3, 3.5. And what charts an inspiration? This point is called triggering. And the point of turnover from inspiration to expiration is called cycling. So remember this terminology. Triggering is triggering or initiating a breath, and cycling is changeover from inspiration to expiration. Okay. So respiratory rate is important because minute ventilation is tidal volume into respiratory rate. Pardon me if tomorrow I will say the carbon dioxide washout doesn't depend on minute ventilation, it depends on alveolar ventilation. We will discuss that when we discuss COPD. A slight introduction to the mode of ventilation, because that is the set of instructions we are giving to the machine, the mechanical ventilator, how much to give, when to give, how, in what mode to give. So these instructions constitute the mode. And how do we decide which mode is good for a particular scenario? There are n number of reasons. So summarizing, it depends on the indication of mechanical ventilation, depends on whether the patient is passive or paralyzed, his background medical condition, technical feasibility, whichever mode your ventilator supports, we can use. And of course, the expertise of the clinician or the ICU team also matters. Now, speaking about the breath cycle, now we are coming to full-fledged mechanical ventilation. We are going to push in breaths and to monitor the breaths. You need to be familiar with three terminologies for sure. One is mandatory breath, spontaneous breath, and assisted breath. Mandatory breath is breath initiated by the ventilator, and the ventilator performs the full work of inspiration during those breaths. Okay, So ventilator starts, ventilator maintains, and ventilator decides when to change from inspiration to expiration. In spontaneous breath, as we breathe, you and I breathe, all initiated by the patient, and the patient performs the entire work of inspiration for those patient-initiated breaths. In between, there are two categories actually. One is assisted breath. These breaths are initiated by the patient, but the ventilator performs at least some part of the work of inspiration for those patient-initiated breath. So patient initiates breath, but a little bit of help is there from the ventilator. More details Dr. Anoop will tell in the second part. And now, after switching the patient from spontaneous ventilation to IPPV or positive pressure ventilation, we need to monitor the patient. We need to look to understand what's happening with the respiratory mechanics. So here is an example of a volume targeted breath. That means we are telling the ventilator, you deliver say 400 ml of tidal volume at a rate of say 10 breaths per minute at an IE ratio of 1:2. So what happens? This is a volume targeted breath. So from the beginning, machine's target is to deliver that 400 ml volume within the inspiratory time. Okay. Here you can see that the flow, this is the tracing showing the flow of flow happening across the circuit. You can see that this is a square wave pattern. Right from beginning, the flow attains its peak and then the flow is maintained till inspiration is ending. And you see the pressure tracing, it goes up and reaches a peak. And this value is called as pressure peak. The maximum pressure value reached is called pressure peak. We don't have a control over it. It's a medical condition or the lung condition which dictates how much should be the pressure peak. We just said we need to deliver a tidal volume of 400. Okay. If the pressure peak is not acceptable, probably we'll have to revise and say I am happy with 325 ml. That's a different issue. We'll go to those things later. So here what I am trying to tell is when the volume targeted breath is delivered, pressure is a dependent variable. Okay, here you can see the initiation or the triggering part. This is the inspiration part, and during expiration, the flow curve goes to the negative side, and this is the typical tracing. This is the tidal volume attained, the peak of volume tracing, and this point also you can note it's a square wave flow pattern. So here you can see the pressure tracing, flow tracing, and the volume tracing. Here you can see the baseline is 0, and suppose I change the settings. Now in the second part you can see that the baseline is elevated, and the new elevated baseline is called as PEEP. That means at the end of expiration, the pressure inside the system is not allowed to come back to 0. It is coming back to a new defined value which is called positive end expiratory pressure. The advantages are many that we'll discuss along with the further characterizing the values. For this point, I'll just mention that the positive end expiratory pressure is the new baseline. Like we say new normal in COVID times, new baseline we are giving to that system. The system is not allowed to come back to 0 after every inflation. The acinus gets inflated and comes back to PEEP. So the acinus collapsing, the risk of atelectasis comes down. Now the second option is you tell the machine I need to build up pressure to say 12 centimeters of water. How much of a volume you are delivering, you are able to deliver, I am happy with it because I need the characteristics of a pressure targeted breath. So here is what happens here. You can see at the initiation of breath, the pressure tracing goes to the preset value of say 12 centimeters of water, and then it comes back to the baseline that we have given, that is the PEEP. Look at the flow tracing. It goes to a peak and then comes down. This is called a decelerating pattern, decelerating flow pattern. Okay, look at the volume. It goes, builds volume and then attains a peak towards the end. Okay, it might attain the desired volume slightly in advance also, depends on the inspiratory time, but this is the tidal volume delivered. So it's clear, the pressure tracing reaches this preset value and it's maintained till the cycling occurs. Cycling is changed from inspiration to expiration, and to maintain this, the flow pattern required is decelerating flow pattern. Just to compare between pressure targeted breath and our previously discussed volume targeted breath, you can see volume targeted breath, the pressure tracing gradually goes and reaches the pressure peak. Here actually it almost instantaneously comes to the preset value. Here the flow pattern is square wave pattern. Pressure targeted, it's decelerated flow pattern. Volume tracing shape also is different. So what I mean to say is, looking at the graphics itself, we can find out whether pressure targeted ventilation is going on or volume targeted ventilation is going on. It's only about familiarity and understanding how this tracing is generated. Okay, so to sum up, this is the transaction of our respiratory system. So initially the flow is generated, it goes to a pathway or trans airway pathway. It's going through the tracheobronchial tree, and then it reaches the respiratory unit, the alveolar unit, the sinus. So the lung compliance depends on this part, whether this part is distensible or not. This much trans airway pressure is, this much work is actually utilized to overcome the resistance offered by the airway. So beyond this, this is the transthoracic pressure. So the distensibility of lung per se dictates transthoracic pressure. In the previous analogies, along the tracheobronchial tree, these are the issues we are going to come across. This is the tubular structure, long tubular structure. When there is a bronchoconstriction, mucus plugging and all, this area will produce more resistance. So that much work has to be done to overcome that resistance. Your peak pressures might go up. This part just depends on the distensibility of the lung units, which is similar to a balloon, and in some disease condition it becomes less decreased compliant, like in ARDS, where distensibility is reduced. So these two will pose two different set of characteristics in our monitored parameters. Depending on that, we'll troubleshoot the ventilator. So remember, throughout the course, you are not treating the ventilator, you are going to treat the patient. So now it's over to Dr. Anoop to take you through the basic modes of ventilation. I understand some more terminology is left, and we'll take it as we go along the discussion. So it's over to Dr. Anoop.
Thank you, Dr. Saneesh, for taking us through this entire jargons of ventilator terminologies and making it so simple for our audience to understand. Before the next session, we would like to announce that there's a certification which will be rolling out. This is a 3-part series, and those participants who are attending all 3 sessions will be getting a participation certificate signed by the speakers. So we would like to remind it that we request all the participants to again participate on the Monday as well as the Thursday session, which will be on the advanced as well as on the COVID related thing. So, Dr. Anoop, all yours, sir.
Thank you so much. So now we will go on to the next topic, one of the very important basic topics in mechanical ventilation. So first of all, I would like to thank all the participants who are attending this event, mainly my friends from Bangladesh, Sri Lanka, Nepal, and our friends from India as well. And we have an excellent number of audience today, and thanks for joining us. So we will move on to the topic. So a few things what I am going to say may be the repetition, but to understand the basic concepts of ventilation, these things should be very thorough. So coming to the goals of ventilation, Dr. Saneesh has already discussed that. Mainly to provide the good oxygenation, we have to provide the minute ventilation, and again we try to give it for the shortest duration. The ventilation is also important. I have already, Dr. Saneesh has explained what is the difference between oxygenation and ventilation. Work of breathing has to be reduced. It should be safe. We have to reduce the ventilator-induced lung injury. The ventilation perfusion matching to be dealt properly. So these are the usual goals. Coming to the modes of ventilation, there are different modes of ventilators. So we have assist controlled mode, pressure support modes or a spontaneous mode, and in between we have something called an SIMB mode. We all were thinking about control mode also, and all the topics we were discussing control mode as well. But dear friends, please understand, there is no control mode in any of the present ICU ventilators. So the control mode is there in anesthesia ventilators, not in any ICU ventilators. Okay. We will explain what is control mode, what is assist control mode, all those things. And again, before going into the modes per se, we should understand what is a mandatory breath, what is a spontaneous breath, and what is the difference. So as you can see in this diagram, in spontaneous breath, that is a completely a patient-driven breath, but sometimes supported by the ventilator. Okay, but when you are coming to the mandatory breath, it is completely driven by the ventilator. But obviously, when you go to an assist breath, a patient is also having a role. So when you are going from spontaneous breath to a controlled breath, the role of ventilator will be increasing. In spontaneous breath, the role will be very minimal, but in a controlled breath or in an assist controlled breath, the ventilator will be having more role than the patient. Now, there are three variables within the breath. So, to understand the concept of different modes, this has to be very clear. The first thing is who triggers the inspiration. The inspiration can be triggered either by the ventilator or by the patient. So, there is a patient triggered breath and a machine triggered breath. So, you have to understand in each mode who is triggering the inspiration. Then comes the what limits the inspiration. Like Dr. Saneesh has already explained. So, whether it is a pressure limited or a flow limited or a volume limited, we will come to that later. And again, how it is cycling between an inspiration and an expiration, at what point of time the inspiration ends and expiration starts. Okay, so these are the three main variables in different modes. So as you can see here, we have like a inspiration and an expiration. So a respiratory cycle will be having an inspiration followed by an expiration. So usually in a ventilator, this inspiratory valve opens, the air will be pushed into the patient lungs, the patient lung expands, then the inspiratory valve closes, then the expiratory valve opens and the expiration, which is a passive process, begins. So this is how the respiration is controlled. Okay. So who is triggering the inspiration at this point? I've already told it can be triggered by the patient or by the machine. And what limits the inspiration, whether it's a pressure control or a volume control, and how it is cycling from inspiration to expiration. So these points are very, very important. Now coming to the two types of triggers, I've already told it can be a ventilator triggered breath or it can be a patient triggered breath. Okay. So here when you can see when it is a like a patient triggered breath, so there is a negative deflection in the pressure waveform, but in the machine triggered breath you may not see such triggering. Okay. So any mode with a trigger setting also indicates that is a assist control mode. Okay, a control mode doesn't require a triggering setting at all. Okay, so we have a different types of triggers as well. That this is a flow trigger and this is a pressure trigger. If you ask me which is better, when this pressure trigger was introduced initially, that was claimed to be better, but later on the studies have failed to prove any advantage of one method of trigger over the other. So both are equally useful. Now coming to the assisted versus controlled breath. So here you can see here this is a deflection. You can see a negative deflection is formed. The ventilator detects that. So this is how you like adjust the trigger. So by adjusting the trigger, the ventilator senses that the patient attempts a breathing, then the ventilator delivers a tidal volume. Whereas in a controlled mode, it doesn't have any synchrony with the patient respiratory effort at fixed time interval. Suppose like you keep a respiratory rate of 10. So the total one cycle is 60 seconds. Okay. So every 6 seconds, one respiration has to be triggered. So every 6 seconds, the machine will deliver one breath. That is mean by a controlled breath. But in an assisted breath, even if you keep a respiratory rate of 10, the machine will see whether the patient is attempting and it will be synchronized with the patient effort. And if the patient is breathing in more than 10, say like 14, 16, etc., those breath also will be supported by the machine. Okay, that is called an assist controlled breath. Okay, and I've already told you there is nothing like a control mode. Even though we say there are control modes, it is only theoretical now. All the modes at present day ventilators are assist control modes or spontaneous modes. So forget about the control modes. Now again coming to the spontaneous versus mechanical breaths. So this is when the patient breathes. You can see there is an inspiration and an expiration. So and here you can see the inspiration is always negative and the expiration is a positive. So the negative intrathoracic pressure is formed and you inspire inside. Whereas in a mechanical breath, even the inspiration is a positive breath. Okay, so this is a positive pressure ventilation. Whereas in inspiration, the inspiratory part will be a negative pressure deflection. Now coming to the cycling. The cycling means how the inspiration is changing from or the respiratory cycle is changing from inspiration to expiration. So that can be time cycle. I have explained. If you keep a respiratory rate of 10, that means like every 6 seconds one respiratory cycle will end and another will start. So in 6 seconds your inspiration and expiration should end. So in that 6 seconds itself you have an option of I ratio. So how to divide between inspiration and expiration. So if you keep an I ratio of 1:1, that means you will get inspiratory time of 3 seconds and an expiratory time of 3 seconds. So after 3 seconds, the inspiration will cycle to the expiration. Okay. And same way, if you keep it as 1:2, the total 6 seconds will be divided into 2 seconds for inspiration and 4 seconds for expiration. So the inspiratory time here will be 2 seconds, and at 2 seconds the inspiration will end and it will move on to the expiration. And it can be sometimes volume cycled and flow cycled as well. Now I've already told the cycling when the inspiration is ending and the expiration starts. So this is the time cycle. I've already told. If you are keeping a respiratory rate of 10, so the total will be the 6 seconds from this point to this point. And if you keep an I ratio of 1:1, at 3 seconds the inspiration will end and it will move on to the expiration. So this is a ventilator control, and it can be depending on the flow cycling as well. You can adjust at what level of flow limitation, or when the flow is coming down, whether at 25% of the peak flow or 50% of the peak flow, it has to cycle to the expiration. This is possible especially for a spontaneously breathing patient, and this is called an expiratory trigger sensitivity. So we have different breaths. This is a like pressure controlled breath. This is a volume controlled breath. We'll come to that later. And this is where a pressure support spontaneously breathing patient. So different types of breaths are, this should be very clear. One is a controlled breath. Controlled breath means triggered, limited, cycled by the ventilator. The patient has no role at all. The ventilator decides at what time it has to start, at what point it has to limit from inspiration to expiration, and after like how much cycles of respiration has to be given in a minute. That is called a controlled breath. So the controlled breath is completely driven, 100% driven by the machine, and the patient has no role. And in an assisted breath, it is triggered by the patient. The patient usually trigger the breath, but it is limited and cycled by the ventilator. So once the patient triggers that, the ventilator decides how much tidal volume has to be reached, what is the pressure it has to reach, and how it has to cycle. That you can do by setting either inspiratory time, which is called as TI, or by setting a IE ratio. Then we have supported breath. This is again triggered by the patient, limited by the ventilator, and again cycled by the patient. Here it is cycled by the patient, but in a assisted breath it is cycled by the ventilator. And we have a spontaneous breath, which is completely controlled by the patient. So we have a different controlling system, a pure spontaneous to completely driven by the machine. So the modes like a CMV mode is a completely controlled mode. The modes like assist control mode, VCV, PCV, etc. are assist control modes, and we have other spontaneous modes like CPAP and again CPAP with pressure support. And in assist control modes also, you can have an assisted breath, you can have a controlled breath, you can have a supported breath and spontaneous breath as well. This is not for the modes, this is for the types of breath. So in each mode, you can have these different types of breaths, which we'll come to that later. Here again, this slide is very important. The concept should be very clear. So I've already told the machine decides at when to trigger, then again when to like limit, and when to cycle it. So the triggering, limiting and cycling is decided by the machine. All the three stages are controlled by the machine. So this is a controlled breath. Then we have a assisted breath or assist controlled breath. So here the patient triggers the breath. It is the flow or volume limited, and it is flow volume cycled. And when we have the pressure support, it is again the triggered by the patient, the limited. If it is a pure spontaneous mode, the patient only will limit. Otherwise, it will be limited by the machine, and it will cycles. Okay. And coming to the modes as well, if you go with a pure control mode, we don't have that. Majority of the modes are assist controlled, and we have other spontaneous modes as well. In between, we have SIMV modes also. We will discuss all those things in the coming slides. So before going to the modes, you should understand different components of pressure as well. So the beginning of inspiration, the inspiratory valve opens, the pressure gradually builds up, and it reaches the maximum pressure. This maximum pressure is called peak inspiratory pressure. Then if you keep an inspiratory hold, either by a mechanism or by a maneuver of inspiratory hold, or if you give an inspiratory pause, the pressure measured at that alveolar level is called as plateau pressure. This is the plateau pressure, and the difference between peak inspiratory pressure and the plateau pressure is called as trans airway pressure. Okay, so this corresponds to the airway resistance, or it is called as a trans airway pressure. Okay, and here it is basically the plateau pressure and followed by the expiration. So we have an inspiration, peak inspiratory pressure, followed by the plateau pressure, then the expiratory pressure. And majority of the time we are concerned about the plateau pressure, even if the peak pressures are very high, especially in conditions of obstructive airway disease. We have to measure the plateau pressure and keep it in a safe level below 30. So how you measure the plateau pressure? In majority of the ventilator, you can see the procedures. In the procedures, there is something like a inspiratory hold. Hold time you can keep it as 2 seconds. Then you press this button. So after holding that in the inspiration, you have to just press the button. After 2 seconds, it will automatically release. Then it will give you what is the plateau pressure and what is the compliance. The compliance measured at the plateau pressure is called as a static compliance, and the different types of compliance are depending on the lung dynamics. It is called as the dynamic compliance. So majority of the time we will be concentrating on static compliance. Okay, once again I'll tell you, in the procedures you go for inspiratory hold, press the inspiratory hold button, then after the inspiratory hold button releases, it can show you the plateau pressure and again the static compliance. Now coming to the modes of ventilation, I've already told we have a spontaneous mode and a mechanical mode or a control mode. In that the mechanical mode we have volume targeted breaths and again pressure targeted modes. Okay, so spontaneous breaths, the mechanical modes, in that we have volume targeted modes and pressure targeted modes. And I've already told mechanical we have volume and pressure targeted modes. So coming to the spontaneous breath initially. So here you can see initially you can see the pressure deflection, then the pressure is generated and you can see the corresponding volume generation also. This is a pure spontaneous breath. If this volume is not enough, say suppose the patient is generating a flow of pressure of only 10 and the volume reached is only say 200 ml. You want a volume of 400 ml. So here you have to give a pressure support. So the pressure support will be given so that the target volume will be reached or the volume will be augmented. Okay, this is the spontaneous breath. Now what is a CPAP? CPAP means you are applying a continuous positive airway pressure, otherwise it is called a PEEP. So in PEEP you can see when you apply a PEEP here, the pressure will never touch the baseline. A minimum pressure will be always maintained inside the alveoli so that more and more lung will get recruited. It will not collapse. Again, when the patient develops something called an auto PEEP, which we will explain in the subsequent modules. So at that time also, by giving a constant pressure, it will keep the alveoli bended so that the auto PEEP also will be less and the triggering will be better. We will explain all those things in the subsequent modules. So when you keep a continuous pressure, it is called as a CPAP or PEEP. Again, you don't have a pure CPAP modes nowadays. It is called a CPAP with pressure support. So this is that CPAP with pressure support. Here, when the patient is breathing, a minimum pressure is always maintained. Then along with that, I've already told if you want more volume, you give more pressure. So at what level you need the pressure, that is determined by the pressure support. You can keep a pressure support of 10, 12, 15, etc. Suppose if you keep a pressure support of 15, the target volume is coming as 600. As you know, we need a target volume somewhere around 6 ml per kg only. So for a 60 kg, roughly around 360 to 400. So you subsequently reduce the pressure support to 12, and when it is still, if it is somewhere around 500, you can again reduce it to pressure support to somewhere around 10. If it is more, again you reduce to somewhere around 8. At 8, if you are getting an adequate tidal volume somewhere around 400, you can keep at that pressure support itself. Don't reduce the pressure support from 6 or 8. A minimum of 6 or 8 pressure support is required. Why? Why you need a 6 or 8 pressure support? Because when the patient is breathing through the circuit, there is a resistance offered by the circuit. That has to be minimized by giving a pressure support from outside. That is why please don't go with a 0 pressure support while weaning. You have to use a minimum 6 to 8 pressure support. Or in GE ventilators and all, we have something called a spontaneous breathing trial, or in some other ventilators you can have some mode called like a tube compensation, so or like ATS, etc. So in tube compensation also, depending on the tube size, the patient weight, etc., the machine will calculate what is the support required and the machine will decide on that. The same way when you put on spontaneous breathing trial also, depending on these parameters, the machine will decide. Otherwise, in simple way, you understand that how to titrate the pressure support. So in CPAP with pressure support, so what are the knobs you are going to adjust? The first thing, you have to adjust the mode. We keep it as CPAP with pressure support. The FiO2 has to be adjusted. Then the pressure support, I've already told this is the support. From the PEEP, how much support we are delivering. Okay, and this support depends on the effort the patient is generating. This is the patient generated pressure with the additional pressure support what you are giving. So if the patient is having an adequate the pressure generation, you need a minimal pressure support of 6 to 8. Okay, so by how to titrate the pressure support, you look at the tidal volume. If the tidal volume is more than what you want, then definitely you can titrate down on the pressure support. Then you have the backup respiratory rate and the backup respiratory the pressure you can keep. So if the patient is becoming completely apneic, the machine will switch over to the backup mode where you have already set the IE ratio, the respiratory rate and the pressure control. Okay, so here you can see the main parameters we will be setting are the FiO2, pressure support and PEEP, 3 parameters. And obviously you will have to, whenever you adjust these modes, there is another control. If you press this CPAP, the pressure here you can see the other controls. In that, always adjust the inspiratory trigger. If you keep an inspiratory trigger too high, somewhere around 5 to 6 etc., the patient may not be able to trigger it properly. The same way, if you keep a trigger very low, somewhere around 0.5 etc., like each slight movement or pressure change in the system, the machine will detect as a patient effort and the machine will deliver the breath. Okay, that will cause auto triggering or multiple triggering. That also should not happen. And you can adjust the expiratory trigger sensitivity, and depending on the expiratory trigger, you can have an adjustment on IE ratio. And you can the safety features at this mode will be, you can adjust what is the maximum pressure, the minimum rate. So when the patient is going below the minimum rate, the patient it will move on to the backup mode. The backup the inspiratory time and backup the pressure support also. What is another parameter which you can check, which you can set here? Anyone? We can set an apnea time also. Suppose if you keep an apnea time of 30 seconds, even if the patient is not generating any breath for 30 seconds, the machine will wait. Even after 30 seconds, if there is no breath, the machine will move on to the control breath, where you have already set up what is the IE ratio and what is the like backup pressure. So if you keep a T inspiration, obviously the rate and IE ratio will be fixed from that, and the pressure control mode also it will move from here. From spontaneous, now we move on to the other modes like the volume targeted and pressure targeted, and in that also we have different modes. So first thing is a control mode. So in control mode, I will make it very clear once again. None of the ICU, the present ICU ventilators are having control mode. The old VCV, PCV, or your IPPV, all those things in different names, it is all assist control modes. None of the ICU ventilators are having a control mode. It may be available in a like a anesthesia ventilator or a bellow ventilator. So here what you have to understand is what is the difference between a volume control mode and a pressure control mode. Here you can see the volume is limited. Suppose I am setting a volume of say 400 ml. So every breath the machine will deliver 400 ml. But depending on the compliance means the distensibility. So how easily you can expand the lung in simple terms. So if a lung is very compliant, your pressure will be minimal. So the pressure will depend on the lung compliance. Okay, but your tidal volume will be constant. So what is the problem? Suppose if the lung is very stiff, then the pressures will shoot up too high and that can produce barotrauma. So here, whenever you put the patient on volume control, while in the monitoring slot, you have to always monitoring peak and again P plateau as well, because you don't have a control over peak and P plateau. That depends on the compliance. Okay, so here in volume control, the volume is controlled and volume is kept constant, and it is depending on the preset tidal volume, the tidal volume what you are setting, and the pressure will vary depending on the length status. Then we have the pressure control mode. Again, this also we are not using, no control modes. But here what is the difference? Here you are setting the pressure control, like you set a pressure control of 20 centimeters. So the machine will deliver a 20 centimeters of pressure, and the tidal volume will be varying depending on the patient compliance. So what is the problem if you keep a patient on pressure control mode? Yeah, like I have put a pressure control mode of 20. So in the ICU when I am going, it was delivering a 400 ml tidal volume. I am very happy. Suddenly patient develops a pneumothorax or going for a significant bronchospasm. What will happen? The ventilator will deliver the same pressure, 20. But as it is like less compliant, the tidal volume generated will be very less. The lung is very stiff. Even if you give 20 centimeters of pressure, the volume reaching will be very less. So what will happen? It will go on to hypoventilation, carbon dioxide retention. The patient can go on for severe acidosis and other complications. Okay. And again, if the lung is too compliant, it can again produce huge tidal volume and it can produce volume trauma. Okay. So in pressure control, you have to monitor the volume generated, and if patient is going for spasm, the volume generated will be less, but the pressure will be normal. So the chances of barotrauma will be less, but your bedside nurse should know how to monitor this mode, and they should see that the volume delivered are constant and it is not decreasing. If it is decreasing, they have to increase the pressure control levels. Otherwise, patient will go for hypoventilation. This is about volume control mode. Sorry, pressure control mode. So I think you have understood the concept of what is volume control breath, what is pressure control breath, and what is a control mode. Here, every breath is the machine triggered, and it is cycled and limited by the machine. The patient is having no role at all. And to put a patient on control mode, you have to completely paralyze the patient. Otherwise, there will be huge asynchrony. But don't worry, none of the present modes are control mode. All are assist control modes. Now we will move on to the next mode. This is very, very important. This is called an assist control mode. So when it is a volume targeted ventilation, we call it as ACVC or assist control volume mode, or sometimes it is called as VEC, or sometimes it is called IPPV. So different companies will be having different terminologies. That is why you should have a very strong concept about what is this assist control mode. Even if the name changes, if your concept is clear, you don't have to worry. So here you can see the patient will be triggering, then it will be limited by the machine, and it will be cycled by the machine again. Okay. Suppose if the patient is not breathing, what will happen? The machine at the fixed time, because you are setting a respiratory rate also, if the patient is not triggering, the machine will deliver that breath. Suppose I am keeping a respiratory rate of 10. If the patient is breathing at patient is not at all breathing, machine will give 10. If the patient is breathing at 6, if 6 will be synchronized with the patient, the rest of the 4 will be given by the machine. Same way, if the patient is breathing at 15, every 15 breaths will be synchronized, and that will be at the set tidal volume. Here you are setting the tidal volume. So if it is, you are keeping a tidal volume of 400, all the patient triggered breaths also will be at 400 ml. So all the breaths will be at 400 ml itself. Okay. So the patient will be having a constant volume, and the pressure support at different level will be depending on the patient effort, and the machine will automatically sense that. Okay. So this is the beauty of this mode. So it will synchronize well with the patient. Even if the patient is not breathing, the machine will sense and trigger, and the volume will be always constant. So what are the parameters you will be setting here? Mainly the mode will be AC. This is sorry. This is the sorry. This is I'm sorry for this thing. This is actually AC/PC. This is the pressure control mode. I will come to that later. So this is what sorry. This is actually here it should be tidal volume. The tidal volume should be in mLs. So in the mLs means it should be somewhere around 400 ml. Then you should have to set the FiO2. This is actually ACVC, and this is the FiO2 you have to set. The tidal volume you have to set at 400 ml or whatever tidal volume you want. Then you set the respiratory rate. Then you set the inspiratory time, or whenever you set the inspiratory time, the machine will show you what is the IE ratio. You don't have to manually calculate that. So the moment you put the T inspiration and changing the T inspiration, you can see what is the IE ratio. Then you have to set the PEEP, and obviously you have to set what is the maximum pressure limit. So these are the parameters: FiO2, tidal volume, PEEP, and sometimes flow also you will have to set. And majority of the ventilator you don't have to set the flow nowadays. And the timing like IE ratio and rate you have to set. The synchrony depends on the inspiratory trigger and bias flow. That is why always you have to see into the main settings and see the trigger settings are adequate. Usually by default you keep it around 2. It can be either pressure trigger or volume trigger. The safety depends on the P max or the P or the P limit. Here again you can see the patient or the machine triggers. It is a T inspiration. Then it will move on to the expiratory cycle. Sometimes in the inspiration you can give a T pause also. The T pause can be used to improve the oxygenation. And when you put a T pause, you don't have to put an inspiratory hold to measure the plateau pressure, because while putting T pause itself will show you the plateau pressure and it will give you a constant tidal volume. Here you can see the volume will be constant, but the pressure will be varying. This is about AC/VC. Okay, so that is about AC/VC. Now we have another mode called pressure controlled assist mode or assist controlled AC/PC. That means assist controlled pressure controlled mode. Here again you can see the pressure is constant. I have already explained that. The volume will be varying depending on the patient lung status. And again it can be either patient triggered, or if the patient is not triggering, the machine itself will trigger at the set rate. Here you will be setting, instead of tidal volume, you will be setting inspiratory pressure. Other parameters are same. The mode you can adjust. Here it is AC/PC, then inspiratory time or IE ratio, PEEP and P maximum. So here depending on the inspiratory pressure, your tidal volume will be changing. So how will you set the inspiratory pressure? You put an inspiratory pressure of 20 and in the monitoring screen you see what is the tidal volume. If you want a tidal volume somewhere around 400, by putting 20, if you are getting 600 ml, you gradually come down on inspiratory pressures. Then like titrate in such a way that you are getting a tidal volume of somewhere around 400. And as I've already told, you have to see what is the inspiratory pressure, other parameters you have set as well. Okay, and this is the, here you can see the pressure is constant always, but your volume will vary depending on the patient lung compliance. And here you can see the upper part is always flat. You don't have to do an inspiratory hold maneuver or an inspiratory pause. The whatever pressure control you have kept above the PEEP. Okay, again this is, you should be very careful. Some ventilator will show you the total pressure control up to here. Something will show you the pressure control above PEEP. Okay, in pressure control above PEEP means to see the plateau pressure you have to add pressure control with PEEP. But majority of the ventilators and GE ventilator etc., it will be inspiratory pressure. So in that it will be plus the PEEP. That means you don't have to. It will include the PEEP also. So whatever will be the P inspiration, so that will be the plateau pressure. Okay. Here it is. This P inspiration is above the PEEP. So here to see the plateau pressure, it will be PEEP inspiration plus PEEP. And again we have inspiratory time and expiratory time. You divide between inspiration and expiration depending on the IE ratio. So now in assist control, what happens? I've already told. The patient can trigger, then the machine will give a pressure control. The machine will cycle. This is the yellow is for machine. The next patient is triggering, but after that the patient is going for an apnea. Then the machine will sense that, because the rate we have already set, the machine will deliver the breath. But here also you can see the machine delivered and the patient triggered, both the breath will be of same quantity. In the sense, the volume or the pressure will be same depending on the mode you are selecting. Then again the patient can, or if the patient is breathing, the machine will sense that and machine will deliver. This is the assist controlled breath. So now we compare the difference between a pressure controlled breath and an assist controlled breath, a volume controlled breath. I've already told. Here you can see this is a volume control mode. So here you are setting the tidal volume. So here you can see the volume will be constant, but the pressure will vary depending on the lung compliance. If the patient is going for a severe bronchospasm, the pressure will shoot up. So here you have to monitor the pressure always. And again, to get a plateau pressure, you have to either put an inspiratory pose, you have to add inspiratory pose, or you have to hold in a inspiratory hold maneuver. But in a pressure control, you can see the pressure set is constant, but the tidal volume will depend on the lung compliance. If the lung is becoming more stiff or the resistance is increasing, the volume generated will be less. So you should be very careful about that. Whenever you put the patient on pressure control, you have to monitor the tidal volume. Otherwise, patient can get underventilated and go for the complication. Now go on to the next mode, SIMB. This again, the concept should be very clear. What is the difference between assist control mode and an SIMB mode? Here you see, this is the like a machine is triggering the breath. In between, patient can also breathe. So when this SIMB mode was introduced, the whole concept was, when a machine triggered breath is given, the muscle will be having more exertion because you are giving a positive pressure. In between, if the patient is allowed to breathe, definitely the muscle will get a less workload, or the work of breathing can be reduced. This was the whole concept when the SIMB was introduced, to give muscle rest during the spontaneous breath. That was the concept. But what happened later on, when it was studied in lab, especially animal lab, they conducted electromyogram leads to the intercostal muscles and the diaphragm. So in that point, ideally with the SIMB principle, the EMG, the threshold or the EMG, the force should be less when the patient is breathing, spontaneously breathing, so that at this point work of breathing will be less. But it was showing there is a more work of breathing during the spontaneous breath. So for whatever reason this SIMB was introduced, it was not serving that purpose. So with those studies, SIMB was getting outdated, and nowadays nobody is using SIMB. You don't need an SIMB at all. Okay, I've given you the reason. It will not give you a less work of breathing during the spontaneous breaths. And what is the other problem? See, here you are giving say if it is a volume control, here you are giving a 400 ml. This is a machine is giving a 400 ml. But this patient triggered breaths, it depends on the patient effort. It can be sometimes 100 ml, it can be sometimes 200 ml. So it will be varying. So you don't have a proper control on these spontaneous breaths. Whereas in assist control, even if patient is triggering, this also will be at the same 400 ml. Okay, so the muscle exertion will not happen. Whereas in SIMB mode, here the patient will have to exert more. That is why we are not using those modes. So how this SIMB is later changed? The patient triggered breath, you can support it with something called a pressure support. So in an SIMB, you have to set the volume, you have to set the minimum rate, and you have to set the support also. Suppose if the patient is generating only 200 ml, you can increase the pressure support gradually, say like 10, 15, etc. to reach at a volume of around 400 ml. But here again, when the patient effort changes, even if you keep a pressure support of 15, and target 400 ml. Sometimes it can overshoot and reach 500 ml. Sometimes it can downplay and it can reach only up to 300 ml. So that is the difference. So here you don't, even when you keep a pressure support, you don't have a proper control on the tidal volume generated. Whereas in assist control, whatever the machine generates here, for the patient triggered breath also, that will be the same. So what are the parameters you will be setting here in SIMB with pressure support? Here you have to set the FiO2. Here you have to set the tidal volume, a minimum rate, inspiratory time and IE ratio. Along with that, you have to set the pressure support. I've already told the pressure supported breath, how much it has to be supported, the PEEP and the maximum pressure. Okay. So this is the pressure supported breath, and this is the spontaneous breathing period where the patient can breathe and the machine can support using the pressure support. So these are the parameters we will be setting in a SIMB with pressure support. And when you take their SIMB with the pressure support or SIMB volume control, I've already told, you can set the main parameter FiO2, the tidal volume, PEEP and pressure support. And don't keep the PEEP 0. Always we keep a minimum PEEP, which you assume as a physiological PEEP of around 5. If you keep a lesser PEEP, again whatever length recruited, it will get re-recruited and weaning will be difficult. And sometimes you can have leak compensation, trigger compensation, backup mode, etc. You can keep a backup mode also whenever you keep an SIMB. If the patient is go for continuously as for apneic episodes, it will convert it into whichever backup mode you have kept. But here you can always keep a minimum rate. For that minimum rate, IE ratio as well. So if you keep a rate 12, then the patient can, if the patient is apneic, machine will give 12. So if the patient can, if the patient want to breathe more, the machine can also, the patient can, in between these 12 breaths, the patient can breathe more. So how sorry, this is ACVC, this is SIMB and SIMB with volume control. Okay. So now we have this, the pressure control SIMB. We have a volume control SIMB and a pressure control SIMB. The difference is simple. Here you set a pressure control instead of volume, and here again you can support the pressure. You can, here again the volume will vary, the pressure will be constant here, and the patient triggered breaths will be having a less tidal volume. So in SIMB pressure control, again all the settings are same, except instead of tidal volume you set a pressure control here, and again you can see the pressure control. This is the pressure control wave. In between the patient can breathe. Okay. But as I've already told, SIMB pressure control we are not using nowadays, because this is the patient can have more work of breathing, and the same purpose can be served with the assist control mode. So how you use an SIMB mode? Even if you want to use, suppose if I keep a rate of say 14, the patient will be delivered a minimum 14, and the patient is breathing at 10. The 10 will be synchronized, and rest will be the machine delivered. Okay. Suppose if the patient want to breathe more, patient can take at a 16, 18, etc. That how much support has to be given, you can adjust with that. So how to use an SIMB? So you can gradually reduce the set rate, and patient will start developing more spontaneous breaths, and gradually from when you reach a very less spontaneous rate, very less controlled rate, you can move on to the CPAP mode or a completely spontaneous mode. But nowadays we won't use that. What we usually do is, from this this assist control mode, when the patient is completely comfortable, your FiO2, PEEP and all are in a acceptable manner or an acceptable range, you directly go from AC assist control mode to the spontaneous mode. So what is this spontaneous mode? So here in the spontaneous mode, you have only few adjustments. You adjust the FiO2, you adjust the pressure support, PEEP and the Pmax. But safety features, you can keep a minimum rate, a backup mode. For the backup mode also, you can set the tidal volume, respiratory rate, etc. Here you can see all the breaths are the patient triggered, and you can see how much support has to be given. I've already told. Initially, you start with a high support, see the target tidal volume, then gradually you come down on the support, and when the patient reaches comfortably delivers a tidal volume and rate at a support of 6 to 8, you can think about extubating the patient. You don't have to go for a TP's trial again. Directly from CPAP pressure support mode, you can extubate if the patient is stable. Or you can use a spontaneous breathing trial also. You can use this CPAP pressure support mode. So these were the things that we were discussing today. In next module, we will be discussing more on setting the ventilatory parameters, alarm setting, how to set the PEEP, what is lung protective ventilation, what is a baby lung concept, what is driving pressure. I've already told about plateau pressure. So by knowing plateau pressure and PEEP, how we can decide on driving pressure, what are the other advanced mode. We have just discussed the basic mode, what are the advanced mode. So you please attend the module 2 also. In module 3, we will be more oriented on clinical part, where we will be discussing how to wean from mechanical ventilation. I've already told you how to do that, but we will explain in detail how to monitor a patient on a mechanical ventilation, what are the infection control practices, the case scenarios, mainly 2 case scenarios, how to do an ARDS ventilation and COPD ventilation, and the importance of COVID-19, how to ventilate COVID-19, what is this L-type, H-type, or type 1, type 2 type of lungs, what are the other infection control practices. So please attend module 2 and module 3 as well. Those who are attending all these 3 modules, we will be giving an online certificate as well. And thank you so much for attending our session. And we have already having a online training module in acute care medicine. This is called WebinarCAMPUS. If you search for WebinarCAMPUS, we have an FB page and we have a YouTube channel as well. So all the acute care related topics you can see in our WebinarCAMPUS YouTube channel and Facebook page. And we regularly conduct sessions, at least 1 or 2 sessions every week. So please follow that. And we have a WebinarCAMPUS channel also in the in Telegram. So you can join the Telegram WebinarCAMPUS. So we will put all the educational events in that. You can note my personal WhatsApp number and email ID as well. Any doubt if you have regarding the topic what we have discussed, or any doubt regarding the WebinarCAMPUS or acute medicine, you can personally contact. My number is 9961085558. This is the Indian number, and this is my email ID, dranoop@gmail.com. You can contact me. And this WebinarCAMPUS is run by myself and my teacher, Dr. Saneesh. So we have different modules in that, different pillars in that, like infectious disease, critical care, anesthesiology, etc. So please follow that as well. And for the time being, I'm stopping. Please attend our next modules also.
Thank you, Dr. Anoop. Thanks for taking through the entire modes and most abstract theme which you had taken through and broken down into simple pieces so that at a granular level, the participants can get the concept of it. So thank you very much for taking through the entire gamut of the basics of ventilation. And I hope there is a good amount of information shared and there's a clear carry home message for our participants of today. And now we would like to open the poll questions. As mentioned at the start of this session, there's a poll option at the bottom of your page. And there are 2 modules, one for Dr. Sanish's session and one for Dr. Anoop's session. There are 4 questions in each module. So if the participants can take those questions now, because after the end of the session, we would like to assess that how much concept has been transpired. So if the participants can take the poll question, we will wait for about 2 minutes and then we will update this thing. And the questions will again be discussed by the speakers. So please open the poll question and attend that question. So we will wait for 2 minutes and we will resume back. So meanwhile, the poll result is getting out. Dr. Saneesh and Dr. Anoop, we have a lot of questions also coming up from both of your sessions. After the poll
Okay.
results, we will take some of those questions. Some of the questions are probably which will be well suited for the next session on the advanced concept processing with respect to lung protection and appropriate pressure setting, PEEP setting, and other things, which I think you will be covering in a greater detail in the next session. So once these results are out, I think you can discuss on those questions, and then we will discuss on. Some of those questions you can take up for today, considering the time. And
Yeah, Dr. Prabhu, that is
so,
very much expected because there will be definitely overlap, because what we have done today is just laying a foundation so that everybody can just revise or just have a look into the basics concepts, so that next session onwards, like the day 2 onwards, we can go more clinical, and we can proceed with the terminology, the proper terminology itself, now that most of the terminology or knobology are already explained. So that was the idea. Today we were laying the foundation, and most of the questions, I think the people practicing in the ICU, or they are working, the work is related to ICU, they will have more queries. Mostly it will be related to their clinical settings. So ultimately we are not treating the mechanical ventilator, we are treating the patient, but definitely the settings also matter. So those things definitely we can take in the coming days, but all the questions related to the fundamental concepts we'll try to address today itself. So
thank you, sir. And you rightly said that we are ventilating. We are setting the. We are managing the patient, not the ventilator. That was a very powerful statement. So as the question keeps coming in, okay, let me say that.
okay.
The first question on the poll is that which among the following is not an indication of mechanical ventilation? And majority of the majority of the participants has replied fever with respiratory rate 22 breaths per minute.
Yeah, actually, I
That's the highest.
deliberately avoided listing all the conditions. I gave a broad category only, like problems with oxygenation, ventilation, problems with airway protection. But yes, people who are familiar with these things, they should be able to understand, like post cardiac arrest with irregular breathing pattern. Yes, definitely we need to pitch in. Severe hypoxemia with altered sensorium, mechanical ventilation is definitely there. Under general anesthesia, because we need to maintain oxygenation ventilation, we have to do it. Following severe head injury also, we need to have an invasive airway and control the ventilation. Fever with a respiratory rate of 22, first you correct the underlying causes, and probably if the condition advances, probably mechanical ventilation might come into picture, but just with fever and respiratory rate, no way. Fine. We are happy that our audience is well read. Dr. Prabhu, how about the second question?
Yes, sir. Yes,
Pick out
sir.
the true
So
statement.
the second question is pick out the true statement. Majority of the audience has said compliance and elastance are irreversibly related. Inversely related.
Okay, fine.
And again, it's a split verdict, and some 113 people has said that compliance and elastance are inversely related, but more than 75 participants also have said that all of the above are correct.
Yeah, but there is a general tendency among the residents or students to go for the all of the above, none of the above, because they still have the hangover of their entrance times. So resistance of airway does not affect peak pressure. No, when the airway resistance goes up, peak pressure also goes up. Typical example is bronchial asthma or COPD exacerbation. Asthma usually decrease lung complaints. No, it is more to do with the tracheobronchial tree and the trans-airway pressure. Pneumothorax increases the trans-airway resistance. No, actually, when unilateral pneumothorax, one lung is gone, so there is no scope for expansion. So the compliance is lost, not the tracheobronchial tree airway resistance. Yes, I have mentioned in my lecture that compliance is won by elastance. They are inversely related. That's the true statement. We'll go to the third question regarding mechanical ventilation. How is
Yes,
the
regarding
machine
mechanical
is?
ventilation, it is anonymously, I think more than 180 participants have voted for can be invasive or non-invasive.
Yeah, actually, deliberately we didn't discuss about non-invasive ventilation, or we didn't stress about it. Non-invasive ventilation is definitely there. To go for an invasive device or not is a different decision. Negative pressure breathing, nowadays we don't do that. Always maintains hemodynamics is difficult because there will be hemodynamic repercussions when we switch from negative pressure breathing to positive pressure breathing. Used only to correct oxygenation issues, no ventilation issues, and even airway protection and maintaining the respiration process also comes into the play. And it's not indicated in comatose patients. It's a wrong statement. It is definitely indicated. So we are happy that people are still thinking about non-invasive options also, because when we manage the patient in real-time scenario, that option we need to consider seriously.
Yes, sir. So the fourth question is find the true statement. And again, the majority verdict goes for triggering refers to initiation of a breath, with very minority of participants saying all of the above.
That means my slide and the message has gone through. Okay, I'm happy for it. Triggering refers to initiation of breath, because tomorrow onwards when we say triggering, we may not explain. Okay, triggering is this, cycling is switching from inspiration to expiration. Cycling is switching from exhalation to inspiration is wrong. Inspiration to exhalation. Okay, normal air ratio is not 1:1, it's 1:2 or above. Mandatory breath cycles are initiated by either patient or machine. No, mandatory breath cycles means machine has full control. So tricky option of all of the above also will not feature. Okay, next one. Find the trigger
Yeah,
parameter
thank you,
for
sir.
mandatory breaths.
So here again, it's a split verdict. I see that almost more than 100 people has said all of the above or any of the above, and more than 75%, 75 participants have said time.
Okay, fine. I think next time we should avoid any of the above, all of the above business, because that is misleading the younger brigades, I think. Time is the parameter which machine uses to start a controlled breath or mandatory breaths. Okay. A breath that is triggered by the patient, limited by the ventilator and cycled by the patient is referred to as. I don't think people
Yeah,
will go for any of the above.
here again, for this question, again, there is a split verdict between supported breath and assisted breath. Almost 50% split is there between supported breath and assisted breath.
Okay, and Anoop, so here actually it's supported by the machine because it's been triggered by the patient and cycled by the patient. In between, there is some support. Okay, fine. So during volume control ventilation, application of inspiratory hole gives what? So you can't go wrong on this, but I expect, Anoop, my audio is muted.
This
Sorry, here
everybody can
the
attend.
unanimous decision. I think most of the participants have mentioned plateau pressure for this question.
Yeah, okay. So I think that makes our life much easier for day 2 when we discuss about driving pressure and all. So since our audience is familiar with the plateau pressure, so we are happy for it. So regarding pressure support ventilation, which of the following is wrong? I think this is the last question. Huh? Dr. Prabhu, did you
Yes,
get
sir, this
any
is the last
response?
question. And yes, sir. Yeah, this is the last question. And the response again is here. It is kind of, we have the responses everywhere. Almost 78%, 78 participants have said we can set respiratory rate, tide volume, and IE ratio. And then for the remaining 4 responses, there is an equal number of almost 30 people for each one have said that flow cycle or pressure initiated or patient triggered, assist
Okay, yeah,
ventilator, assisted
I think
ventilatory mode. So it's kind
again
of
from the
everywhere the
hangover
results
from
are.
the entrance time, because again people may not read the question well. So is the person setting the question wrong or the question wrong is a question. Okay, we are actually asked to pick the wrong statement, and option E is the wrong statement. We cannot directly set the respiratory rate, tidal volume, or IE ratio. All other things are actually qualifications for the pressure support ventilation mode.
I think the question was a bit confusing. People
Yeah.
may be very familiar with the concept, I feel. So don't
Yeah,
worry. Also miss
so
miss this
that's
question.
what I said, whether the question is wrong or the person setting the question is wrong. So next time we should avoid these wrongs and any of the above, all of the above. I'm happy for a good response from our audience. I think they are listening very carefully, and I think now we'll take the question from the audience.
Yeah, so that brings the end of the poll questions for us. So quickly, if we can, for the rest of the next 15-20 minutes, if we can quickly look into the questions that has come from the audiences.
Yeah.
And the last question, as it goes with the pressure support ventilation, there are a lot of questions or requests has come up there to explain PSV. If you can briefly explain the PSV. So that's something of frequently asked questions I'm seeing here. If you can again paraphrase it in a simple way as a take-home message on what is pressure support ventilation.
So the pressure support ventilation is otherwise called CPAP with pressure support. Here it is a completely the patient-driven breath. I've already told it's a spontaneous mode. You don't have a minimum rate or maximum rate, etc. The rate is completely determined by the patient, but the tidal volume is usually decided by the patient, but definitely you can support it with the pressure support. Okay, so this is the commonly used weaning mode also now. So once you start the patient on CPAP with pressure support, you see whether the patient is going for apnea. That is why you have a safety option of keeping a backup minimum rate and minimum tidal volume depending on your backup inspiratory pressure. Okay, and initially you start with a slightly higher pressure support. You gradually reduce the pressure support, and once you reach a pressure support of somewhere around 6 to 8, don't go below 6 to 8 because you need a minimum pressure support to reduce the resistance offered or to neutralize the resistance offered by the circuit. Okay, so once the patient is comfortable on a PEEP of say PEEP of 5, a pressure support of 6 to 8 with an FiO2 somewhere around 30 to 40, you can think about extubating the patient. Okay, so this is the pressure CPAP with pressure support. This is otherwise called pressure support as well. This is completely patient triggered and a complete spontaneous mode. I think that's very clear.
Thank you, sir. So before taking the specific questions from some of the audience, there are some questions which is very common. Many people have asked this thing. Like there is a question on, can you explain bias flow again? Can you explain what is the PS rise time, the expiratory trigger, and the difference between the T inspiratory and the IE ratio? This is something frequently asked question. So on the timing, on the flow, and on the rise time.
I will take that T inspiration and IE ratio, but the rest Saneesh sir will explain.
Sure, sir.
For this IE ratio, I've already told you an example. Suppose I am setting a respiratory rate of 10. Very simple. So one respiratory cycle is 6 seconds. So 6 seconds into 10, we have a 60 seconds. So this 6 seconds, how we are going to divide? If I want to divide like IE ratio 1:1, that means equal time for inspiration and equal time for expiration. So you need 3 seconds for inspiration and 3 seconds for expiration. So if I keep an IE ratio of 1:1, that will give you a 3 seconds inspiratory time and 3 seconds expiratory time. So instead of keeping an IE ratio of 1:1, I can set a inspiratory time of 3 seconds. Okay. Now coming to another example, the same rate, 10 rate, I am keeping a IE ratio of 1:2. So the total 6 seconds you are dividing into 3 parts. So 1 part for inspiration, 2 part for expiration. So 2 seconds for inspiration and 4 seconds for expiration. So if I set a TI of 2 seconds, it will be IE ratio of 1:2. Clear? This is very simple. If you set a TI in the machine itself, majority of the ventilator, our G ventilator, it will show you what is the IE ratio. You don't have to manually sit and calculate like the old ventilators. So the once you start setting the TI, it will show you what is the IE ratio. Or if you are setting the IE ratio, simultaneously it will show you what is TI. So both are almost same. You should understand the concept. That's all. The rest,
I think
Saneesh
by the
explain.
time we set the rate, one duration for one breath cycle is fixed. Okay. Next, once we specify either the inspiratory time or IE ratio, the division is also defined, well defined. So that's it. So if you are setting the inspiratory time, remaining time goes for expiration, and you can simply get the ratio between I and E. In the ventilator, I think you can have a screen of set parameters and monitored parameters. Along with the setting the parameters, usually there will be the second variable also appearing. Like the moment we turn the knob for inspiratory time, the change in IE ratio also will be displayed in the screen itself. So we will come to that in detail when we discuss about COPD ventilation, where we'll be stressing on the expiratory time duration and the IE ratio with its clinical implications. So in general, in a nutshell, to remember probably expiratory time, we are thinking about CO2 washout. Inspiratory time, we are thinking about oxygenation. Is one of the indicators related to oxygenation. That is why in refractory hypoxemia, we go for inverse ratio ventilation, or rather increasing the inspiration time duration, proportion of duration, because our concern is oxygenation. COPD, we will try to prolong the expiration because we need more of CO2 washout. So that's the idea.
Thank you, sir. And so we have got a lot of questions here, so I think we quickly
I
move to the
think
next
that
question.
the issue of bias flow we'll discuss when we are discussing the high frequency oscillatory ventilation.
Sure, sir. On rise time, sir. Would you like to take up on rise time?
Rise time is actually the time taken from the baseline to the peak of pressure. I think there was a graph, right now I don't have, maybe next day I can show that how fast it is attaining the maximum line. If you are setting a pressure control of 12, how fast the value from switch from the baseline to the pressure control value is the rise time. If the rise time is more, it will be a slowly rising curve. If you observe the pressure tracing, the rise time is less, it will fast attain the peak and then go to the plateau. So basically, if the rise time is less, the pressure is attained faster. You might require a higher flow.
Usually, I think from 0 to 500 milliseconds is the window that is provided for the ventilators, wherein you can really play with that time. So that the speed with which you can increase the velocity of the flow to reach the peak.
Yeah. So that actually we can minimize the inspiratory time. You do get the job done faster. Okay, so that's the idea that will correlate with the clinical things when we discuss the case scenarios. So this is the basic concept. Rise time is the time allowed to reach from baseline to the set value.
There's a question on bilevel mode and SBT. Brief explanation of it. Bilevel settings, functions, and the spontaneous breathing trial.
The bi-level setting during the advanced mode, we will discuss that today.
Okay, so we can park that question now.
Yes.
On SBT, you'd like to?
SBT, I've already told you what is an SBT. So here you just set the parameters, like how much time, the patient parameters, etc. The machine will only set what is the pressure support, etc. Like manually you can do with the CPAP pressure support. The same thing you can do it with the help of machine in the SBT. The same way you have these automatic tube compensation mode also will do the same thing. Here, instead of setting fixed parameters of pressure support, PEEP, etc., you can just put the patient on SBT, and the machine will only sense whether the patient is tolerating all those things, and towards the end you can assess all those things and you can decide.
So in a sense, is it kind of a weaning predictor for the clinicians?
Yeah, exactly.
They are trying to predict a successful weaning from ventilation to extubation.
Yeah.
Okay, so there is a specific question from Dr. Gayatri. Details about recruitment of lung. I think this is in great detail you will be covering in the second module.
Yeah, all such
So I
details.
think we will park this question because it will be covered in the subsequent session.
Yeah,
Uh,
PEEP titration, driving pressure, recruitment, ARDS management, all those things will be discussed in detail.
okay. So can you explain the square wave and the decelerating wave flow pattern briefly? Question from Pooja.
Yeah, can I share this screen?
Yeah, please.
Yeah, square wave pattern of flow we usually we use in volume targeted breath. Here actually we give a, this is the flow pattern right from the beginning of or triggering. You get a continuous flow, a constant flow for some time till the breath cycles from inspiration to expiration. Okay, because of this continuous flow or high flow of pre-mixed gas, our pressure gradually goes up. Eventually, we will meet and attain the desired tidal volume. Okay. In pressure control, things are different where we try to attain the set pressure control value from the time of trigger. Okay. To attain it, this is the rise time. From the baseline, it goes to the set pressure value. Okay. So this is the rise time. Once, if you want to reach the set value at the earliest, you need to start with a very high flow. And once the pressure is attained, then you need to reduce the flow to maintain the volume. So this is the decelerating pattern. If you look at the flow pattern in the spontaneously breathing patient also, physiological breathing also, you can see there is a peak inspiratory demand during the beginning of the inspiration. So this decelerating pattern of flow somewhat is similar to our physiological flow requirement. That is why the square wave pattern is not too physiological, and our decelerating pattern looks more towards the physiological pattern of flow. So for volume control breath, it's a square wave pattern. The flow suddenly reaches a peak and then is maintained throughout the inspiration. For pressure targeted breath, it starts from a high value, then decelerates throughout the inspiration. Anoop, you want to add anything to make it more simple?
Yeah, the same. It basically depends on the initial flows. So depending on the patient demand, and again, to make the synchrony better, you can use these different types of flow patterns. And usually, we don't play much with these flow patterns nowadays.
Yeah, okay. I think the difference is clear, I believe. We'll get the feedback
Yeah.
from the person who has put the question.
Yeah.
So there's a question from Dr. Sudhindra. Limit and cycle. Ideally, whatever limits the breath inspiration should also lead to cycling. Then why describe as separate entity? Why are
No,
limit and cycle described
no,
as
no.
separate entity, not
Limiting and
as?
cycling are different because say you want to attain a volume of say 400 ml. The moment the volume attains 400 ml, then the machine, the breath cycle, the message is stop. You have attained your target. But then wait till the I ratio is maintained or the desired inspiratory time is maintained. Suppose I have set an I ratio of say 2 seconds is to 4 seconds in a 6-second breath cycle. So you attain the tidal volume, desired tidal volume in maybe the first 0.5 seconds. Then you have to wait till another 1.5 seconds as a pause or holding. And the moment the timeline touches the 2 seconds, then the machine will know it's time to open the exhalatory valve and go for exhalation. So this is the idea of cycling. The cycling depends on this I ratio or the inspiratory time set or other parameters. Sometimes it will be dependent on the flow patterns. That is a different entity. But the limiting is something which says this is the target. Pressure limiting means attain a pressure of 12 centimeter. That is it. You attain and then wait for the next signal, that is cycling. When the cycling signal comes, then you go for exhalation. That's why these two are different, limiting and cycling.
Thank you. So I think that should clarify the query on this thing. Again, there are a few questions coming on expiratory trigger. If you can briefly explain how it works. The spontaneous breath, the expiratory trigger.
Expiratory trigger sensitivity in pressure support ventilation.
Yes.
In pressure support ventilation, the breath is initiated by the patient or the client, whoever. Okay, the patient initiates the breath, and then you give a support. Okay, say maybe 5 centimeters of water, and then the decelerating flow pattern comes down from maybe 100% value to 50%, 25%, 75%, 50%, and 25%. Most of the time, if you keep the expiratory trigger sensitivity as 25%, the moment the flow pattern comes down to 25% mark, then the machine decides it times to open the exhalation valve and go for exhalation. Okay, so this way we are actually indirectly modifying the respiratory rate. Suppose instead of 25% expiratory trigger sensitivity, I keep it at 50%. From the maximum value of flow pattern, from 100, it comes to 75, 50, then machine says enough is enough, go for exhalation. So then the breath cycle cycles from inspiration to exhalation. That is how the expiratory trigger sensitivity indirectly modifies the respiratory rate. So basically, by default, usually from 100%, when it comes to 25%, the flow cycling occurs by default setting, sometimes 30%. If you want to increase the exhalation time further, you change the expiratory trigger sensitivity to say a higher value like 50%. So from 100%, as soon as it reaches the 50% decelerating pattern, it cycles to exhalation. So you give more time for exhalation, especially in a COPD patient. Is it clear?
Right, sir. So essentially, it is the cycling trigger which cycles from
flow cycling. We are
right?
modifying. We don't allow the machine to wait till 25%. We are telling the machine change the setting so that probably yes, at 50% you can cycle to exhalation. We will get more of exhalation time. So we are indirectly modifying the I ratio in a spontaneous pressure support ventilation module.
Right, sir. It's a question to explain the static compliance in brief by Rijay Rajan.
Yeah, okay.
Static compliance.
Compliance I have explained is a distensibility, how much volume is attained with a given pressure. Okay, static compliance, the word static itself says it is compliance decided at a static level. That means when there is no flow. So in the graph shown, I think when do you get a situation where there is no flow? I'll try to show that graph. So that is when you have an inspiratory hold. Okay. So here you can see this is the volume control breath. It reaches a pressure peak, then you get an inspiratory hold, then there is you get what is called as plateau pressure. Okay. So PEEP is the raised baseline. So imagine there is no PEEP. Imagine that PEEP is 0. So at this pressure, pre-plateau, this is the volume attained. So static compliance is volume attained divided by plateau pressure. Because at this phase, there is no gas flow. It's static. Okay. If there is PEEP, you reduce the PEEP. So volume divided by P plateau minus PEEP. Dynamic is you don't get a still phase, like no gas flow phase. So there is no inspiratory hold. The pressure value we have is pressure peak. So volume divided by pressure peak is the dynamic compliance. If you have PEEP, then you reduce the PEEP from the pressure equation. So volume divided by pressure peak pressure minus PEEP. Okay, so that will give you dynamic compliance. Okay, once again, static compliance requires a no gas flow scenario. So you take inspiratory hold phase, that is, you take the pressure as plateau pressure. So tidal volume divided by plateau pressure. If there is PEEP, tidal volume divided by plateau pressure minus PEEP. Dynamic is there is no inspiratory hold, no static, no stagnation, nothing. So you get tidal volume divided by peak pressure. If there is PEEP, you reduce the PEEP. That is dynamic compliance is tidal volume divided by peak pressure minus PEEP. Okay, the implications are different. We'll discuss it further when we discuss the lung protective ventilation, because the plateau pressure minus PEEP is the driving pressure. That is the pressure with which you inflate the lung units. How much should be the driving pressure and all, we'll discuss along with the lung protective ventilation strategies. I think Dr. Rejoy, your doubt is clear.
Yeah, yes, sir, for that. And same participant have asked one more question, that is the inspiratory trigger always flow? I think that was answered by Dr. Anoop, that it could be either flow or pressure, and our literature does not really favor any particular trigger.
Yes.
So I think I'll move to the next question from the same user. I think, is there any minimum pressure that need to be set to overcome the ET pressure, ET tube?
That we have already
Is
told.
that
Not minimum pressure, minimum support. It is to overcome the resistance offered by the circuit and the tube. So we set it somewhere around a minimum of 6. So if you reduce less than 6 centimeters of water in pressure support, obviously the work of breathing will be more. Or when you go for this ATS mode, etc., ATC, acute tube compensation, etc., automatic tube compensation, sorry, that will again reverse the resistance offered by the circuit.
So how much is enough is basically indicated by the patient also.
Yeah, clinically assess and decide.
If patient is not happy with that, then probably you will have to go. There is no universal standard value, but this is the arbitrary practice in our modern day practice.
so? Does tube compensation have any role here, sir? Automatic tube compensation or resistance compensation, do you think have any role in adjusting to the patient's need when the endotracheal tube size is different?
Again, it is a calculator-based assessment of pressure support. Here you can clinically assess the patient. So you have to sit with the patient. You have to assess whether the patient is comfortable. You are generating adequate tidal volume. It's almost both are same. So if you are at bedside, you can assess the patient. Well-experienced person, I still prefer doing a CPAP with pressure support rather than going for these automatic modes.
I remember somebody mentioning about snorkeling practice. So even physiologically fit persons, when they do the snorkeling, they'll know how much effort it is required to breathe through the tubing. So forget about that. We are